Right, I think we'll start. Good morning, everyone. You're all very welcome to this webinar on men and COVID-19. I hope you're all keeping safe and well. Our thoughts this morning are with those that have been worst affected by COVID in recent months. My name is Noel Richardson. I'm Director of the National Centre for Men's Health at IT Carlow, and I also work half-time for the HSE on the implementation of Healthy Ireland Men, Ireland's National Men's Health Policy. The webinar this morning has been organised by the Engage partners. And for those of you that don't know, Engage is Ireland's National Men's Health Training Programme, which is a key pillar and capacity building measure for the implementation of our National Men's Health Policy. The programme is funded principally by the HSE, and the other partners are the Men's Development Network, who have a national coordinating role for the programme. And then there's the Men's Health Forum in Ireland, IT Carlow and WIT. Just in terms of background to the webinar this morning, it's still early days, obviously, as we kind of get to grips with COVID-19, but the early indications are that there are some interesting sex and gender differences in the transmission, incidence and mortality rates from COVID-19, and these we feel are worth exploring. There's also evidence of certain population groups being more at risk. So the issues like race, ethnicity, social class also seem to have a real bearing on the outcomes for COVID-19. But we also know that the statistics are really just the tip of the iceberg, and we've all been massively impacted by COVID-19. So the wider ramifications of the pandemic and how we come out of it is really worth exploring, and that's something we'd like to look at in terms of this webinar as well. So these are just some of the issues that our keynote speaker, Professor Alan White, will grapple with shortly. Just in terms of an overview of the webinar, after this short introduction, Alan White will give a 25-minute presentation, thereabouts. Then the second half of the webinar will be a question and answers kind of discussion between Alan and I. We would really like you to be involved by using the chat function on the webinar, and I'll just say more about that in a second. So there'll be lots of opportunity hopefully for engagement in the second half of the webinar. Just before we start, just a few kind of practicalities and housekeeping. There are over 100 on this webinar, so for obvious reasons, then it's not possible for everyone to engage, you know, using their voices, as it were. So you will be restricted to the chat function on your screens. But I would encourage you, if you just scroll over, if you haven't used this facility before, if you scroll over the desktop and go to the chat function, and maybe at this stage, if you haven't done so already, you might just say hi and give us your name and where you're from or your organization, so we'll have a record of who's on the call. So that would be great if you could do that. If you have any comments or questions or reflections during the course of Alan's presentation, just use the chat function to register those, and I will do my best to kind of capture those and to bring them back to the discussion that I'll have with Alan in the second half of the presentation. This webinar is being recorded and it'll be available on the Men's Health Forum in Ireland website afterwards, just to let you know that. Right, so without further ado then, I'll introduce you to Professor Alan White. Alan was the founder and co-director of the Men's Health Centre at Leeds Beckett University, and is now Emeritus Professor of Men's Health at University since his retirement in 2017. Alan, I think it's not an exaggeration to say, has been a massive influence and a true pioneer in the field of men's health now for many years. His passion and devotion to his work has been a real inspiration for many of us in the field. So there's no one better placed, I think, anywhere in the world to present this session this morning on men and COVID-19. So Alan, no pressure, over to you, thanks.
Thank you very much. It's a sheer delight to be with you and to have the opportunity of sharing some thoughts on what we know about men and COVID-19 and what we don't know. And actually, what we don't know is probably more important than what we do know. because there's just, as you know, it's just a tremendously impactful disease that has gone across the globe, from a very simple start in Wuhan in China in December. We are now somewhere completely different with global impact. And I'm very proud to have the opportunity of speaking to you. And the slides will be available afterwards. I think that going back to what I've just said, this is a new disease, and it's quite incredible how much we're finding on a day-by-day basis. It's part of the coronavirus group of viruses. There's been 8 previous coronaviruses identified. The 2 most important was the 2003 SARS, the severe acute respiratory disease, and then the 2012 MERS, the Middle East respiratory disease. And actually, what we find is now people are referring to this because about 85% of the virus is similar to the SARS of 2003. We call it SARS-CoV-2 as well as COVID-19, so you may see the 2. And this is just an interesting one. MedArchive is a website where people put papers that have not yet gone through proper peer review. And yesterday I went on and put in COVID-19, and since December there's been 2,441 academic papers put onto this site, just this site. Today I rechecked, it's 2,638. So between yesterday and today, another 200 academic papers covering all aspects of this disease have come online. So what do we know? Generally, globally, there are about equal numbers between men and women testing positive. In Ireland, we have more women. It's 57% of women, 42% of men, 67 unknown gender. But the important thing is that we don't know yet why we're having these equal numbers. Is it because we're testing more younger women because of their role in the caring profession? Is it because they're getting it, or what? So there's some uncertainty around the cases. What we do know is men are more at risk of developing serious illness, and we're going to see this as we go through. And we may be recovering more slowly from the virus, especially overweight men, as it's stored within the adiposity. You've had in Ireland about 1,476 deaths, with a higher death rate, 51% men, 49% women. Deaths among confirmed cases, 7.5% males, 5.2% female. Now, globally, there's quite a lot of difference there, and some of the data will be from the UK, where we've got it. Now, how do we get it? First of all, what we're finding is one of the most important ways is droplet. It's the virus load which is making the difference. And if you're in a room where people are laughing, are coughing, singing, we're seeing some of the super spreaders where they've been the biggest outbreaks have been where we've got people in confined spaces where people are shedding more of the virus. There may be also some mist that when we're talking or in a supermarket, but that's less important. We're finding, I think we could say that it's not having the same kind of impact as the heavy load that you get when you're faced with a sneeze or a cough or laughing, singing. Funerals are terrible. This is weddings have been shown to be an area where spreading has occurred. Formites, the hard tables, the objects, some passage, but it's not been seen as important as the droplet. So common symptoms, what we're finding also is that there are people who have been identified as being more at risk. And the common symptoms that people are coming forward with, though, are respiratory. So about 70% of them have got cough, fever, 65%, shortness of breath. These are the ones who are going on into more serious illness. Systemic muscle pain, joint pain, fatigue, but also enteric. So stomach, abdominal pain, vomiting, diarrhea. 4% of those that have been admitted to hospital have only had enteric. We tend to think of it just as lungs, but actually it's a broader thing. Of those who get it, about 80% have a mild form of the disease, and about 14% go on to have the severe form of the disease, with 5% critical. But we're seeing about 98% survival. But what we're finding is that we're getting more men into that severe case category and the critical. So the severe disease is when you have a bigger dosage of the virus. You find it when you're in the older years, over 65 years, the median age of those being admitted to critical care or of death are 72 years. Respiratory disease, COPD, 19%, asthma 14%, so they're very important. Cardiovascular disease, those people with hypertension, heart failure, diabetes has been seen very important, obesity, chronic renal disease, liver disease, and those who are immunocompromised, so people who are going through chemotherapy for cancer and such like. In America, the three main issues were hypertension, obesity, and diabetes. So people with pre-existing disease, and we know that for nearly all of those that I've got listed there, for chronic conditions, men are predominantly the ones who are most at risk. And here we can see data from the UK with men on this side and women on this side. And we can see that the age effect, men are being affected much more greatly in the early years. These are the people outcomes with greater number of deaths in the UK, ongoing care continuing to be in greater numbers, and discharged. And in the UK, 3/4 of those who die in intensive care are male, and 2/3 of the deaths under 85 are male. So we've certainly got an issue about it being a more serious illness once you get it. Now, why is that the case? Now, there is a lot about the biology, there's a lot about the behavioral science of this and social cultural, and I'm just going to try and run through some of this stuff. For those who don't know, this is the XY chromosome, and that's the X chromosome on the right-hand side, and that little beggar there, that's the Y chromosome, that's us. And a lot of the immunity of the body is coordinated through the X chromosome, which puts an immediate advantage for women because there's 2 X chromosomes in women, and therefore they have a duplication of that. And we'll come back to that in a minute. So possible biological explanations: age, over the age of 65, mainly because there's high rates of severe disease, but there are other factors in relation to hormonal levels, and the prevalence of other factors such as angiotensin enzyme 2, which I'll come on to shortly. Lots of comorbidity, which we've seen, obesity, which we've seen. Women have stronger immune response generally. The oestrogen, the TLR7 gene that they have on the X chromosome are all very much associated with a stronger immune response than you see in males. And this is why also they have more risk of autoimmune diseases like rheumatoid arthritis and thyroid disease and such like, and less cancer in the early years. Testosterone on the other side is immunosuppressive. So whereas the women's hormones are building up their defenses, testosterone has got a tendency to bring it down. Now, angiotensin converting enzyme 2 is not something that we've tended to know much about. And I'm not sure many people in the audience would know much about it, but this is turning out to be a very significant factor, because that is the route in. These little beggars here sit on the cell wall, and as the virus comes back, the virus attaches onto that via a spike protein, fumarin, and which is also more prevalent in males. But these are more prevalent in males. We have more of these. And so therefore it's easier for the virus to get into our cells. Women have it produced on both X chromosomes. And so if the virus can unlock one, it unlocks them all in the male, whereas in females, it can only perhaps unlock one, and therefore there's some immunity left over from the others. It can't get into all the cells. But also what this AC2 does is a very important role in counteracting all sorts of metabolic processes. And it's found within the lungs, it's found within the stomach, it's found within the liver, kidneys, it's also found within the testes. And there's lots of issues now we're finding about how the disease spreads around the body, but also what impact it might have. And once it's gone in, once the virus has gone through, it damages it, and it can't do that main function. So we've got a lot of stuff which is occurring around the biology of the disease. We also know that there's a lot of issues around the intersectional factors in COVID. In the UK, we're seeing that Black males have 4 times the rate of the number of deaths than white males. And when you take out age and disability, you're still finding it's double. So ethnicity is still a significant issue within the UK and I think elsewhere. But I haven't got all the data. We're still waiting for a lot of data to come through. It may well be, as there doesn't appear to be a biological reason, as in there's nothing in the genes that, like sickle cell or what have you. It may well be that an aspect of greater risk of comorbidity. So there may be more issues around cardiovascular disease or hypertension or obesity. But there may also be social cultural factors in relation to shared households or religious practices or other factors, which we are still investigating. Poverty is a big issue. Crowding, we're seeing this within housing, working conditions where people are more together, find it harder to get out, with issues around comorbidity. So there's lots of issues around how we see the poor being affected. And it's also easier for a wealthy person with money to have their salaries protected. They've got houses, they've got gardens. If you're in a city, and most of the big cases are occurring within the inner cities where there's crowding, more people around, you find that is actually a breeding point for a lot of the disease. And quite damaging. Migrant asylum seekers, I think this is very important because a lot of people who are arriving in countries may not be aware of the support services are available, may have issues about language, but not in terms of them bringing the disease with them, but just in terms of the support needs of people from different communities. And I think also there's a whole issue around access to health services and what kind of services are available for people within their environment. Now, behavioral factors. Now, you can see on the list, men have got an issue with quite a few of those potentially. Smoking. The ACE2 is exacerbated, they're more highly expressed in those people who smoke. People who smoke have got greater risk of pulmonary disease. Ironically, we're not seeing huge numbers of people who are smokers coming through the disease to positive status. We don't know why. Alcohol is immunosuppressive in many ways. We're seeing vast increases in the amount of alcohol being bought for home consumption. We don't know quite what the impact is going to be on the virus, but we're not. It's something for the wider concerns, which we'll come on to later. Hand washing. There's data from the SARS outbreak, which showed that men were not efficient, but also not as likely to be washing their hands effectively. So there may be a factor in spreading through hand washing, but again, we've not seen any data on that for this current outbreak. But I'll go back to what we're saying. It's only a month or two old, so we're still very much in the early days of trying to identify what this disease is like. Social distancing. We're seeing some evidence that young men specifically are finding it difficult to keep social distancing, and they are of the the fines that are being put out in the UK. 8 out of 10 have been for men, and a third of them are in the younger age bracket. And there's been another study which has shown that a lot of young lads don't see the need for social isolation and keeping distance, which is obviously an aspect to be considered. Denial of risk is hard to judge. I mean, we're seeing that somewhat in the young lads, but I think most people are very aware of what this disease is and how it can impact on them. Delayed help seeking. Now, this is a really interesting one, because you hear this story about men delaying help seeking, but if any of you have had the virus, had an influenza, the flu, will know that actually some people may not know this mild COVID, may not realize they've had it and they're fine. If you're at the point where you need help, you are very ill. I mean, the people who have called the ambulance, have been taken in, suddenly have found themselves in, or slowly over a time period have found themselves getting more and more ill. And so therefore the delayed help seeking is a tricky one, because people who are able to get through it with the mild versions will just get through it. They may be poorly for a day or two. Those people who have pre-existing health concerns perhaps need to gain guidance more quickly. Health literacy may be an aspect for some of the young lads. We know that there's an aspect of health literacy for males, but we haven't any evidence of that specifically. We also know that behavioral factors in relation to work for men, that more men are likely to commute to work. The evidence is that most men who work full-time and are more likely to commute. So you've got the train, you've got the buses and such like, but that's all being closed down. But close working environments, vans, building sites, the vans are probably more important than the building sites. Building sites more spread out, but for a lot of men's work, it is very close together. It's very engaged and very difficult to maintain social distance. And we also have aspects of patterns of behavior and cultural practices which are important for males, certainly in the Muslim and where the prayers are very much in the all together. Sporting settings, pubs may well be. It's going back to that: the laughing, the coughing, the sneezing, the big droplet formation. Work-wise, we see here, going back, this is the UK data that's just come out, where low-skilled elementary occupations have the biggest risk of death. And you see that when you look into it, security occupations, process plant operations, construction occupations are where we're seeing the most heavily impactful in terms of occupations and death. Senior people, as I mentioned before, are able to perhaps keep away from the risk. For women, caring, leisure and caring services with social care, women working in the social care are having a much higher rate of death than in the healthcare workers. And that goes back to close contact with people. Now, what we don't know is more than perhaps what we do know. We don't have, at the moment, disaggregation of data where it's probably most useful. We know now a lot of the sex data, still not in the UK, but it's getting better. But sex and weight, so we don't know how weight impacts more on men and women. Chronic conditions, all the chronic conditions. We don't yet have the sex, gender, age, sex, gender, ethnicity, socioeconomic status, disability. So once we start to get that more granular data, we'll be able to say more specifically, well, this is why this group is more at risk. What we also don't know is the impact on other diseases. Interestingly, sexually transmitted infections I think are on the way down, because we're not getting people out there. But we are finding studies now showing that COVID is being transmitted in the semen of some young men because of the link with the testes. We have the ACE2 receptors within the testes, and there may be an aspect of impact on male reproduction, but that's something that we will have to look at later on. But someone who's had testicular involvement within the infection, when they've had the infection, may need to look at that. But we're also missing out on diagnoses, because people have not been going to the doctors, or the doctors haven't been open, dentists have not been open, opticians have not been open, so people are missing out on diagnosis. And also there's people delaying treatment, so we don't know how that's going to impact, when we know that men have a much greater rate of cancer in their early years, heavy impact cancers, and also cardiovascular disease. Massive issue around mental health. I can't go into it all now. I mean, but we have men socially isolated. We don't know what kind of effect that's going to have, and how that's going to impact on our suicide rates. We know that gets worse with recession, and my goodness, we're going to go into recession. And I've mentioned the testicular function. So the wider impacts, fatherhood. My goodness, we've got people at home that have perhaps never had that amount of time at home. We've got relationships under lockdown. But going back to the fatherhood, I think fatherhood is a really interesting area for research, for looking at, because I think that, as I say, that children have never had that amount of contact with their fathers or grandfathers if they're in the home. If you're like me, a grandfather hasn't seen my children, my granddaughters, for months now. I am desperate to see my children, my grandchildren. So I should have fatherhood, grandfatherhood on there. Relationships under lockdown, the cauldron that occurs, but also the possibilities that occur through those relationships within that tight space must be something which is quite dramatic in some cases, and the intimate partner violence and abuse is coming out as an aspect, but also perhaps positive stories as well. Separation from family, I mentioned. Boredom and worklessness. Most men, their lives, they have traction through their work. They go to work, they do their job, they come home. This is completely alien to a lot of men's working practices. For women, they have a variety of roles. Men's roles have traditionally been seen more narrowly, and I think that this may be opening up new opportunities for us. The consequence on the economic side of this, Mike, we don't know. I mean, but it is just globally huge. And we also got changes in our patterns of behavior. Our activity levels have changed. For some, they've gone up. For some, they've gone down. People are out walking. We've allowed activity outside of the house, and so that may be impacting on our activity. Our diet may be changing because of being stuck in home, not going out, not eating out, and that may be for the positive, it might be for the negative. Weight gain, people snacking, socializing, how we are forming relationships, how we are maintaining relationships, and certainly our working practices are being dramatically impacted on and what that long-term change might be. Our conferencing, our meetings, our going into work when we can work at home. But for a lot of people, and actually a lot of the people who have been most heavily, they don't have the option of working from home. So this one may be another one where we see the able getting more able and the less able getting less able. So to summarize, this is a new disease and we are very much in uncharted territory. So people are asking for answers, and there are very few answers specifically, definitely, that can be given. People say it will, you get it within 4 days, you have this and you come over it. There's people going on for weeks with this disease. Why? What's happening with children? We tend to find children tend to get impacted very heavily. They're not. Why is that? But there are some strange outcomes. It's just unknown territory. There's a strange disease acting in a strange way. We know we have a higher risk of serious disease and death, and that needs to be recognised. And by gum, if we've not needed a men's health policy before, if we've not needed a more focused approach to looking at men and supporting men, this is it. There are very strong biological as well as behavioural and social cultural factors at play. And there are consequences on many, physical, mental, social, economic, that we just have no idea. And we need a concerted effort to help men get back on the road. And that's my 25 minutes. Sorry, folks, that my little time has just gone up. Thank you very much indeed.
Thank you, Alan. Can you go out of that screen, Alan? Great. Yeah. That was really super, Alan. Thank you very much. I mean, it just is a really super overview of the complexity of it all. You know, like that last slide there, I think captures it really well. It's that intersection between the not just sex and gender, but the kind of structural, biological, behavioral, cultural factors that really are operating in such intricate and complex ways. And it really highlights the importance of not trying to draw kind of simplistic conclusions about this, or not trying to put everything in kind of neat piles that we can, you know, say everything's really clear when it's not. And I think the point you made about what we don't know is really important. So the chat function is now open. I'd encourage everyone who's listening in to just type in any comments or questions or reflections that you might have for Alan. And we'll use those as the basis for the next half hour to kind of formulate the discussion. Just one early question that came in there, Alan, was about smoking and nicotine. Does that infer a higher risk?
Well, it should do. I mean, the smokers have been found to have high levels of lung damage. So when we say that you're more at risk if you've got existing respiratory problems, so that puts you at more risk. And also smokers have higher levels of the ACE2 expressed within their lungs and their body. And so again, that should. Now, what we're finding at the moment is that we don't know why, but there are, we're not seeing huge numbers coming through to the very severe illness. So don't know why. But it's certainly not a protective factor. But it's just inconsistent.
Okay. There's another question there. Is there any different advice or any specific advice you give to men over and above everybody else, or over above women? You know, do men need to hear specific messages about prevention or about management?
Well, I think it depends on where they're working, and it depends on how what kind of experience practices they have. But knowing that they've got more severe disease is very hard, because you can't. If you've got a pre-existing disorder, if you're older male, if you've got a pre-existing illness that is linked to it, then obviously I would be very much more aware of my health. And social distancing is more important, and my hand washing is more important, and being careful, because I don't want to get it. I would be thinking, I just don't want to have that as a possibility. But apart from that, nothing specific, because the general message is the same for all of us. Distance, hand washing, and being careful. And if you feel you've got it, if you've got the opportunity of getting tested, get tested. If not, social distance, keep yourself out the way.
Okay. One of the concerns that's been raised here is that men and women are not presenting with other conditions to emergency departments or other elective appointments with specialists. Like, for example, there's early indications that the diagnosis of certain cancers is down. There seems to be a perception that people should stay away from hospitals because of this fear of contracting the virus, which obviously raises huge concerns about either the lack of diagnosis or the late diagnosis of other conditions. Would you like to comment on that, Alan?
Absolutely. It's so important that we keep normal services. If you've got a problem, you get it checked out. We're seeing a big change in the way that GPs are working. I've heard that there's about less than 7% of our normal practice of going to the doctor and being seen by the doctor. The rest of it's being done by video, by phone. And actually, there's an awful lot of positive work that's emerging about how we can perhaps work in different ways. But we need to get checked. And if there's a problem, we need to, I think most hospitals are separating out the people with COVID from the people who haven't. And they're being very careful about how people coming into the hospitals are being supported and separated out, so that a person with another health condition can still be seen. Ophthalmics, eyesight we need to keep our eyes on our eyesight because they pick up a lot of problems. Dentists pick up on a lot of problems, and yet we're not seeing dental practices opened. But if people have difficulties, they should be trying to get themselves sorted out via their GP, via their hospital, ringing the helplines. But I'm absolutely sure that we're missing problems. And the risk of missing a big problem is greater perhaps for many people than the COVID itself.
Okay, thanks, Alan. A couple of other questions here. One participant has asked about, is a visor or screen more effective than, say, face masks?
This is a really difficult one. I think that there's now guidance coming out from the World Health Organization that we should be following. I think the kind of mask that is most effective is the one that's been saved for the people who are in the most difficult and challenging of areas. This personal protective equipment has been a global problem. For a lot of us, actually just having something which covers our face when we are out will reduce the amount of droplets that we give off, and also the amount of droplets that we absorb, we can take in. The visor, the full face glass plastic visor, I haven't seen any research around that, and I think that there is emerging stuff all the time. So I would keep an eye on the websites for guidance. Government guidance will be trying to guide people as to how best to do that. So I can't say much more than that at the moment, I'm afraid.
Okay, any suggestions about how to target young men specifically in relation to public health?
It's been a problem throughout millennia about how to get young men to see the risk, and it's a whole different debate about how they see the world and what kind of guidance and support they need to be able to make sense of it. And thankfully, they are less at risk. The age range is more the older age range, and the challenge comes when there's older people living in the same house as the younger people, because social isolation or moving people who have got really specific issues into a deeper kind of social isolation is emotionally and mentally very difficult for them. But it depends if the young people are in contact with them. How you get messages out to young lads, I think that there should be more people who are they respect getting the messages out. White middle class men stood in front of the cameras in giving out diktats is not necessarily the best way for them to have the message, when they should be perhaps being more closely guided by a lot of their peers, by the people who they respect in sport and music. At least there is to get some of the messages out there.
Great. Sorry if I'm a bit distracted. I'm keeping an eye on the chat function and trying to listen at the same time.
Yeah.
Is there any research on those that have recovered? Can we learn anything from people who've...
No. Nothing specific about those who've recovered. I mean, some people have come through it. They're changing their treatment programs. I can't go into the details of that, but because I don't know. But they're trying different ways of giving oxygen support, so not as many have to go into to be fully ventilated. Because once someone is ventilated, it's obviously you've got lots of other problems which are going alongside it. Kidney involvement is massive. you've got all sorts of issues around the psychological impact of going through intensive care. I think we're going to have a lot of people who are struggling to rehabilitate from this disease, who have gone through that, the severe form of the infection. So I really feel as though we should be thinking about rehabilitation and survivorship, because there may be also emotional stuff around why did I survive, and why did others die. So there isn't anything that's emerging specifically about why some people come through it. You have 90-year-olds that have mild disease. You have 30-year-olds that can have serious disease. I mean, it doesn't. We don't know yet why it has such a completely different impact on different people.
There's a question on the STI transmission.
I don't know. It just came up in one of the papers. One of the 2,400, 600 papers I was reading.
We might follow up with that and maybe send the reference to somebody who's inquired about that.
Yeah. It's just it was just an observation that I think it was on one of the websites about we're seeing potentially less men out in the community having sex, and therefore the reduction. Also, there's less international travel. There's less. I mean, it's going to be quite fascinating on a morbid level to see how some of these things. This is massive social experiment that's occurred about just locking people down, and how that's going to play out in all sorts of different areas. I mean, we're already seeing benefits within our environment with regard to reduced travel and cars, reduced planes. I mean, there's all sorts of ways in which our health may be benefiting from this in the broader sense.
There's a couple of questions coming through on how the public health advice, or how appropriate it is for more marginalized groups who are living in confined quarters.
Yeah. I think this.
And directed travellers.
Yeah.
The appropriateness of the advice given the disproportionate stress that are on these groups. I mean, is there a comment you can make on that, or what should we be doing more to support these groups at this time in particular?
I mean, you know as well as I do know that the blanket messages out to everybody is almost. It's the only way. I mean, but at the start, but they should be now moving more quickly to having more nuanced guidance, because when you see the data around the deaths occurring in the blue collar workers, the different ethnic groups, the health literacy aspect of this disease, the crowding aspects of this disease, the need to have social practices looked at and supporting people to make a decision about how they live when you don't have the resources that a lot of people have. So I think that it's the right question to be asking at this time.
And a similar question allied to that is, it's about staying connected as we come through and move out of this. Any advice or comments about how we can, I suppose, improve social cohesion or social connectedness in society more generally, especially for more vulnerable, isolated groups like in rural communities?
Yeah. I mean, different groups have different challenges. You've got families that have been thrown together and are living, 5, 6, 7. There's a family of 14 I saw today in the news, how they're managing in a house when they're not able to get out. And then there's me in my house all by myself. So some people have had massive amounts of issues in relation to social family environments which are very crowded, to others that have got big issues around social isolation and loneliness because you're by yourself. The elderly who are now becoming ill and missing their families, that's another big issue. Of funerals where people can't go to a funeral, weddings that are being called off. I mean, it's just tremendously overpowering almost. when you start looking at it, the complexity of what's going on is just massive. And we're going to be, as practitioners, as people working in the health and social sector, education, police, we're going to be looking at this for years to come.
One person has commented about the role of sports people here, young GAA players who've come out and supported public health messaging.
Yeah, I think that
it seems to be really, really helpful in terms of getting buy-in at a population level.
Yeah. I think it's got to be believable. It's got to be of the language and for the people to be able to understand what it means to them. We know that there's an issue around health literacy for a lot of young lads about they've missed the messaging, and so therefore what other way could we get it to them so that they can understand it? Especially around the mental and emotional aspects of this, I think that we've got to find. I mean, in Leeds, we've been doing a lot of work around reaching out to the most vulnerable groups. The Rise High initiative, which is an initiative that's been aimed at the people living in the high-rise flats, where we found that because they're not seen as socially vulnerable, if they need social housing, they're put into the least nice accommodation. 80% of some of the high-rise flats in Leeds are male. And so we identified that when we did the State of Mental Health report in Leeds, and they've now got services going in. Now, obviously, they can't go in at the moment, but they're working around it by having telephone calls. A lot of these guys don't have telephones, so they're thinking about, well, where do they go? They go to if they're going to go out to buy food, to the local shop, so they have the Manbassador program where they're working with the shopkeepers to be able to give them advice as to how to advise the guys. It's about being creative, and I think this is one of the brilliant things which is going to come out of this from the mental health perspective is actually, it's really pushing us forward to think about how we reach and support guys, how we enable men to have services delivered to them remotely if they can't come in. And actually it may make us more creative in the way that we give guidance and support.
Yeah, that aligns with one participant who's talked about COVID being an opportunity for men to kind of reconfigure roles and in relation to caring roles.
Absolutely, and I had fatherhood in. I could have done the whole session on fatherhood, because I think if you're out on that van at 8 a.m. in the morning and you can't get off it till 7 p.m. in the evening, and if you don't get on that van, you don't get paid, then for a lot of guys, they miss out on so much of their child's growth. I think this is going to be an opportunity for us to see some exceptional development of fatherhood as a role. They've been doing schooling with their kids, which is marvelous. But are we thinking about how we support those fathers to be doing those schooling? Do we need to be getting more guidance out to fathers who are doing schooling? Do we need more guidance as to that if caring? Yeah, I think it's an opportunity. We're also seeing men volunteering, which we know men are great at supporting initiatives, and so the creativity around the way we've been getting guys out to support local communities and the roles they've been playing. I think we've got to be positive about some of this as well as the negative.
Yeah, there's a few questions on mental health, and in particular next week is Mental Health Awareness Week. A lot of concern for vulnerable population groups of men who are living alone, men in rural areas. Is there any particular messaging that, like another commentator has said, that peer support services or counselling services being done remotely, that men are missing the connection, that contact? Is there anything in particular, say for Mental Health Awareness Week next week, we should be looking at?
Well, I mean, you know as well as I do know that nothing can beat being together. The men's sheds is is not a mental health initiative, but my goodness, it does men good to get together in that environment where you've got that shoulder to shoulder, you've got the camaraderie, you've got the chat, you've got the laughing, you've got the you can't do that so easily on a video. I mean we've been seeing some great use of video and parents being kept in contact and talking, but it's not the same as actually getting two people, sitting down with them, and also giving them a hug, also personal contact. I mean, it's just I think we're going to be picking up the pieces of this for a while, but hopefully it is making us really think about what men need at a policy level. I mean, we've got to push the politicians to recognise the plight that a lot of the men are under, and to I mean, your Irish men's health policy is just a phenomenal positive for Ireland, but getting it fully implemented and to really get it supported by all is a challenge, and I know, and this may be an added impetus for that.
Yeah, one commentator has also mentioned that, say, a peer support program in the ambulance services has been really effective. So I suppose we should also need to think about vulnerable groups of men, but also workers who are under incredible stress at this time.
Absolutely. My son is works on the ambulance, EMT. He's out there doing the job and seeing people, and it's hard. I mean, and then he's got to go back home to his family, and we have people going onto the front line. And there's a study that's been done in the UK of the deaths of health workers, and 94% of the deaths from doctors are male, 39% of the deaths from the nurses are male. And when you think of the proportion of male-female, I mean, it just shows that we're also having an issue around a greater proportion as a total of male deaths within the professions. But we also see young women. I've been talking about men, and I could equally easily be talking about the enormous challenges that women are facing through this, both health-wise, social-wise, emotional-wise, and if ever there was a time for us to be thinking about how gender is an interrelational factor, and that we have to be working together with our women's health colleagues to be able to think about how we support each other through this
That's a key point, Alan. I mean, the whole focus on gender is not to gravitate towards this kind of men versus women debate, but rather to understand how cultural factors impact men and women differently, how that shapes attitudes and behaviours, and leads to inequalities. So, I mean, that's been a key focus of our policy in men's health, is to look at how we can tackle gender inequalities and work with women's groups in a gender relations context.
I did the state of men's health in Leeds, but then I did a state of women's health in Leeds. And if anyone hasn't seen it, it's well worth it. It's a big report, over 300 pages. And I looked at all aspects of women's health: social, emotional, physical. And it was, for me as a professor of men's health, to be involved in that was a privilege. And as I worked through every single problem that I talked about from a men's health perspective, I was then seeing it from the women's health perspective, and I was realizing time and time again how gendered our physiology, our biology, our social cultural pressures, our emotional, is linked together but separate. We're going through things in different ways, but the implication for each other is massive. And so I think it's an incredibly important thing that we look and see how we mutually support each other through this.
Completely. Alan, we're just coming close to the end. Just some quick fire responses to these questions. Are men slower to self-isolate?
I think it varies. I think the data would suggest that more men are out there getting fined. 8 out of 10 are male, but I think the majority of men are taking this as seriously as women, and we are seeing tremendous support for what's been done.
Okay. Do we know much about reinfection?
No, we don't. I mean, it's an interesting one. It's again where this is a new disease. I mean, how long will the immunity last? I mean, the common cold is a kind of coronavirus, and we know how difficult it is to find a vaccine for that. And you get it, and then the next week you seem to get it again. It's too early for us to have any firm details on that.
One sentence, what does viral load mean?
How much there is. I mean, it snowball bang in the face. That's a snowball load. That's the virus. It depends on how much is present. So therefore, someone who's really sick and coughing and it's in your face, then that is a viral load. That's how much you've taken in. Are
beards higher risk?
No. Well, it's a good question. No, there isn't any evidence. The only evidence for people who are wearing masks, no, actually, there isn't any evidence that shows that it makes a difference, because the mask covers the important bit. And if we keep our hands away from our faces, then no.
Okay.
So keep your beards.
And digital literacy, some commentators saying that there are a lot of people who are not digital.
Yeah, absolutely. My mother has no idea how to put the video function on the WhatsApp. So, I mean, she just can't, she cannot do it. So all our conversations have been with the phone. I mean, and actually there's a lot to be said about that. The good old fashioned phone call is as good as anything else. But I think digital, the time when we should have taught people was before it all happened. And not in the middle of it all. So I think people are growing through it, but I think there's also real issues around homeschooling children when they don't have the equipment to be able to do it properly, or the space, or the Wi-Fi bandage, or anything that where what one person will take for granted, another family will find really hard.
Great, Alan. There's lots of other questions, but we're just running out of time. Can I just give you the final word? If you were to say there were 2 or 3 priorities at a policy level in terms of men and COVID-19, what would you say they are?
Think it through. Think about the implications of COVID for men and for the different groups of men. Get data disaggregated so we have more information about which groups of men specifically we need to be getting the messages out to. Black men, 4 times higher rate of death. Obviously be thinking about what does that mean for their working practices during this current pandemic. Also be thinking about the mental health, the longer term mental health impact of the recession and the social isolation and the difficulties. So be starting to think now about getting support to the groups that do the best work. And the groups that do the best work tend to be the community groups, the third sector, the charitable organizations, so that they can get access to these guys and really give them the support they need. And third is the social distancing and the hand washing has to be seen as an important and life-saving step for the time being.
Brilliant, Alan. That's been so inspiring and so informative. It's really been fantastic. Thank you very much.
Thank you for the opportunity.
And thank you for everyone that joined us this morning for tuning in and for being so enthusiastic on the chat function. My apologies to those whose questions I didn't get to, but we may have some mechanism to follow up with those at a later stage. Just to flag a couple of things before I finish. Our second webinar on men and COVID-19 will take place during Men's Health Week on Wednesday, the 17th of June. More details to follow on that soon. Can I also remind people that Men's Health Week takes place from Monday the 15th of June, and the theme this year is restoring the balance. And finally, a recording of the webinar will be up on the Men's Health Forum in Ireland website in the next few days.
With the presentation.
With the presentation. So that's it for now. And it's just a minute to 12. Well, fantastic chairing, Alan. Thank you everybody for joining us this morning, and keep safe and well. Thank you.